So this is a 56-year-old African-American female with past medical history of hypertension that she was diagnosed with in 2008. She's been non-compliant since then. She presented to the ED today with dizziness for one day, trouble focusing her eyes, and left-sided headache for a few weeks. Her dizziness is aggravated by activity and has been unrelieved since its onset. BP on arrival was 260 over 120. Pertinent review of systems. General, she had no fever, no chills, no weight loss. She had a positive headache with nystagmus, diplopia, no ear discharge, no nosebleed or mouth ulcers. She's positive for neck pain. She had no palpitations, no chest pain, no shortness of breath, no cough. Past medical history was just hypertension. Past surgical history, she denied any past surgical history. She had no history of cigarette smoking, alcohol abuse, or illicit drug abuse. Allergies to penicillin, Valium, and codeine. Family history, no pertinent family history, especially of stroke. Currently, no home medications. Her vital signs on exam was a blood pressure of 156 over 85, pulse of 72, O2 of 98% on room air, and a temperature of 36.9. For exam, her head was normal cephalic, autotraumatic, pupils were round, equal, brisk, and reactive with nystagmus. Lungs were clear in all fields. Cardiovascular, she was regular rate and rhythm with no murmur. Neurologically, she was awake and alert, oriented times 3. Speech was clear with no aphasia or dysarthria. Pupils were equal and reactive to light. She had left interocular ophthalmoplegia and no facial asymmetry, no facial sensory loss. For motor, she had no significant focal weakness, no ataxia. Deep tendon reflexes were 1+ throughout, and sensories and tactile-like touch. Pertinent labs: sodium was 147, potassium 3.2, creatinine was 1.2, which we believe is baseline. She had an A1C of 5.9, LDL of 110, and her UA was negative, and an ESR of 60. So pertinent diagnostic imaging: she went for a CT scan of the head, unremarkable for acute hemorrhage, ischemic infarct, mass effect. Her EKG was sinus rhythm. So for this assessment, this is a 56-year-old female who comes to the hospital with hypertensive emergency and possible CVA. She will transfer to the neuro PCU. So for neuro, we'll continue to monitor for Q2 neuro checks. We will get a brain MRI stat. We'll give aspirin 81 milligrams now and daily. We're going to consult ophthalmology and OT eval. For CV, we're going to control her blood pressure less than 160. She's currently on a carbapine drip. Going to start Norvasc 5 milligrams BID in the AM. We're going to avoid any drops of blood pressure due to the fact that she constantly has hypertension. Respiratory encouragement symptoms barometer and ambulatory status. GI, we're going to start a regular diet, Pepcid for H2 prophylaxis. GU, we're going to monitor eyes and nose and electrolyte protocol as needed. We're gonna PT will evaluate, also speech will evaluate, and then we're gonna start discharge education for the importance of medication regimen. So my takeaways would be: so this patient actually, after she had her MRI, did show signs of a stroke, was transferred to neuro ICU for hypertonic saline and mannitol management. So I would just say, just say your CT doesn't show a stroke, your MRI often will, and you need to watch these patients closely.